Good evening, doctors. My name is Vinu. I run Oyamed. I'm also an academic for three major universities in Brisbane. Teaching clinical skills is my bread and butter. So I'm going to teach you how to do the cardiovascular system physical examination. So the first thing I have to do is that I acknowledge the traditional owners of the land and pay my respect to the elders past, present, and emerging. So I have wanted to do this for a very long time. And the thing that you need to remember is how an OSCE is scored. If you can understand this, then most of what we do will make sense to you. Okay, so if you have given the AMC exam and you see the examiner sitting in one corner and he has an iPad. So pretty much depends on the system AMC uses, and I can't show what my university uses for confidentiality. This is from University of Toronto, and almost all of us use similar system. So this is how the examiner would see it on their iPad. And they would say, if you have done eliciting your chief complaint, so if you have done it correctly, he will click this. If you haven't done it, he's going to click this. And it keeps going back. Every single thing is itemized, every little bit. So there is no chance of error. So usually people say that the examiner was mean to me, or there is racism, or there is this, there is that. There is zero chance for any of those. If you have done it, it will be marked as done. If you haven't done it, it will be marked as not done. That's number one. Number two is that your examiner cannot read your mind. So if you have thought of it and did not verbalize it, it will not be marked. Only what you say can be heard and it will be marked. All right, that's the first thing you need to remember. The next thing is that, so this is how we mark. Done correctly, it'll be done. And I click the, if you have not looked for allergies, I'm going to click and say you haven't done it. So it keeps going. Now, the next part of it is the global rating scale. This is what a lot of people don't get. So assume that in your history collection and history taking and data collection, so we can mark any of this. So is it unsatisfactory? So that means you haven't done it. There were major omissions. Borderline misses several aspects, but okay. You meet expectation. This is at the grade 4 level. You have 0 to 7. So 4 is where you meet expectations. Exceeds expectations, and then you're outstanding. It's the same thing goes for communication. And a lot of doctors do not understand unconscious bias. It is something that you learn to do this. So the unconscious bias is the way you look, your reactions on your face, how much time you spent listening to the patient. All of this is your unconscious bias. And you need to be very careful with that. Your grammar, your vocabulary, the tone, and the volume. So assume you're going to break bad news to the patient. You need to learn how to modulate your voice to a lower pitch. Okay, Mrs. John, I have something to tell you. That is voice modulation. It all counts because they want to know how you would work here in Australia as a doctor. And this is really important. So communication, the verbal expression, your fluency, communication. So we had a workshop for bridging course providers in Melbourne last week. And one of the things AMC said was about English competency. So 10 years ago, everybody needed to pass the IELTS before they sat the AMC exam. But then what happened is that if you fail your AMC exam, it'll take you 2, 3, 4 years to get through the whole AMC too. So your IELTS only has 1 year or 2 years of validity. So then you have to waste money and do it again. So a lot of international medical graduates asked AMC, could you please take the IELTS off? And we will do the IELTS after we have done the AMC too. So which they took it off. But that doesn't mean that the English competency is not required. It's still required because you're expected to work in Australia. English is our major language, so you should know how to speak, how to communicate. So be careful with the English. If you're not fluent, learn. The best way to do it is stand in front of the mirror, speak. You get the fluency very quickly. That is how I did it. So that's a communication. So unsatisfactory, borderline, meet expectation is what we do. Now we have the non-verbal communication. So have you engaged with your patient? Have you been frustrating them or antagonizing the patient, even the examiner? I know someone failed because examiner asked her to use the hand sanitizer, and she said, I did. And the examiner got annoyed with her. I believe that was why she failed. There may be other reasons, but he was annoyed. Don't antagonize your examiner. Don't antagonize your simulated patient. Borderline, difficulty in engaging, frustrating, still antagonism, meet expectations, exceeds expectations, and outstanding. Now, you got to also remember there is something called professional and ethical behavior. You respond to the patient's need in a timely and respectful manner. You need to demonstrate attitudes and professional behaviors appropriate to the clinical situation. So this is one of the things that goes wrong when you rely on recalls. So the same recalls can come in multiple versions. They could change one single identifying factor in it, and it would change the whole case. So if that happens, and then you haven't reacted to the patient, you don't respond to the patient's cue, the patient is saying that, oh, I'm so worried, and you say that I'm sorry, and then the examiner, or even I would ask, are you really sorry? Or is it something that you're practicing? So always think, what is the examiner going to think? How are they going to react to each of the word that you speak? So this is important. So all of this is actually marked. When you do the role play with someone, you got to understand that not just your clinical reasoning, all of this also need to be met. So clinical reasoning. Again, this is something I have said multiple times. And most of the doctors do not understand that there is a difference between clinical knowledge and clinical reasoning. Clinical knowledge is what you did for AMC1. All of those weird questions that you had to answer. So I had a question that was asked, the radiation frequency for X-ray. I still don't know. So that was your clinical knowledge. That's not the reasoning. AMC clinical is looking for your clinical reasoning ability. So whether you understood what is going on with the patient and you managed it, you will pass. So that's reasoning. And then one more domain, overall assessment. So are you in the unsatisfactory, borderline, meets expectation, exceeds expectations, and outstanding. So when you get your MC score, you have your score, the average score, passing score. So the average score is the one where they combine all of the borderline, pass and fail together, and then create an average score. So that is what you see as average score. Your score is exactly what you got based on all of this criteria. And the passing score was always decided before the exam. So do examiners know which station is pilot? No. We all start at the same time. So all the time. So even in the MC clinical examination, on the day of the exam, the examiner and the simulated patient goes through the whole station one time. So they have 30 minutes to go through the whole thing to see if there's anything need to be added, anything needed to be taken, if everything is smooth. All of your simulated patients are professional actors. They take their job very seriously. And I have tremendous respect for them. You should too. So during the COVID time, I was an examiner for my university, and the simulated patient could not come because the patient was diagnosed with COVID. So, and because it was a last minute and we didn't have anyone else, I volunteered to be the patient. And we had 18 students that day going through the exam, and it was an abdominal examination. And after they did all of the palpation of my abdomen, I had tummy pain for another 2 days. So if it is with 18 students, I go through that much. Can you imagine your simulated patient sitting there with 39 of you doing the physical examination? Have mercy to them. Be nice to them. They're actually doing a job. They're trained and they are very, very good in their job. It's not the simulated patient's job to help you. It is your job to get the right history from them. Are we clear so far? Excellent. So now the few things you need to remember. The first thing is the power of the golden minute. The first 1 minute, if you get it right, you get everything right. Because when you walk in, you can see the examiner leaning forward with the iPad. In that first minute, if you've got everything in a systematic order, you will see the examiner leaning back. And that is what you want, because if he's leaning forward, he's looking for every single thing that can go wrong. And he will mark down because you didn't get it right. So if you lean back, he will say, okay, I can let that slide. Maybe 1 or 2, they might slide or they may not. But at least you're better off with the examiner not checking every few bits that you could get wrong. Verbalize would be the next thing you need to remember. I prefer to say there is no evidence of rather than I am looking for signs of. And the third thing you need to understand is you need to take your AMC clinical exam really serious. In med school, if you get 50% right, you would still pass because the professors know you, you know the system, it's your hospital where you worked all your time. You might even know the patients, you might even know what cases you had earlier. And then a lot of you even try to game the system by figuring out which case AMC is going to give, looking at all the recalls. No, you cannot game the system. You need to practice. You need to take this seriously. You need to practice, practice, and practice. You can, especially for your physical examination, you cannot wing this. You really need to know how to do it in that strict time period, how to verbalize it, how to pass, get it over with. So ideally, on a normal case, you might have 3 physical examination, 2 psych stations. So that means if you do your PEs correctly, and there are 72 stations, if you got all of them right, you got your psych, so MSc and MMSc and all of that, that means 5 stations. Then you only need 4 more to pass. So you really need to concentrate on physical examination and your psych stations. Practice, please practice. You remember how you studied for your medicine, where you've read things and you understood? That won't help in your clinical OSCE. Clinical OSCE is a performance. You need to talk, you need to get the history. So even if you understood things, it may not help you. So you really need to get the role play and practice with someone and get all your mistakes corrected. All right, let's go. So how do you do a normal physical examination? So at my university, we follow WIPers, so which is wash your hands, introduce yourself, explain to the patient, introduce your patient, get the patient's detail, explain what you're going to do, and request consent. So introduction of yourself, this is comes in your golden minute. So you need to learn how to do this flawlessly. Hi, my name is Dr. Verghese. I'm here to do a cardiovascular system examination. This examination involves me looking at you, looking at your chest, feeling different areas of your chest, tapping on your chest, and listening to your chest with my stethoscope. And for this examination, I need you to take the shirt off. I will position you at 45-degree angle. If you're a female, you can continue wearing your bra, but I will still need you to take your shirt off. Is that okay with you? Done. That is all you need to do for your introduction. So you have explained what it is, you've got the consent, and now if it is a private examination like DRE or anything like that, or for the chaperone, you need to wash your hands, and you always need to ask the patient, are you in any pain at the moment? Remember your Hippocratic oath, you're not to harm your patient, do no harm. So always check the patient if you are in any pain. Now, I'm very bad at drawing, but I have had this drawings since I came to Australia, because this is how I teach all of my med students, and this is how you need to remember. So in a normal examination, we do the full inspection of the patient, and then you start from the hand, go up, then you go to the eyes, nose, the cheeks, the mouth, down the neck, to the chest, down the leg, to the toes. And that order is really important. Why the order is important? Remember, in the iPad, everything is itemized and everything follows an order. So if you miss the order, your examiner needs to scroll back and find where it is. Are they going to do it? I don't know. Do I do this? Most of the time, no, because I'm exhausted, mentally fatigued sometimes after listening to the same thing. Because remember, every single doctor who is coming in is going through the same case. It's mentally fatiguing. So if I do it, maybe, maybe not. Depends on the day and how tired I am. So CVS exam overview, general inspection. You inspect the hand, palpation of the hands, you check the pulse, you go to the neck. So neck, face, chest inspection, palpation, auscultation, inspection for cushion, auscultation of the back, check the sacral edema, pedal edema. This needs to be up and down. That's for soft, sorry. So you're inspecting from the end of the bed. Describe the patient's body habitus. Can anyone tell you why you need to know the patient's body habitus in a cardiovascular system examination? I run an interactive session, so I like you to talk. I don't want you guys to sit there quietly. So why do we need to describe a patient's body habitus in a cardiovascular system examination? Anyone?
Cachexia for the heart failure.
Pardon me?
Cachexia, to rule out the cachexia for the heart failure.
Aha. Okay. What else? Anybody else?
Marfan syndrome,
Okay. So what in Marfan syndrome are you looking for?
the long limbs, long fingers,
Mhm. And one more.
high arched palate,
Yeah, but that we can't see in the general inspection, right? So in the body habitus, there should be one more.
obesity,
BMI. Yes, BMI. You want to know is your patient obese or not, because cardiovascular disease risk increases if the patient has obesity, right? So that is why we need to know the patient's body habitus. Dysmorphic features. Yes, you're right. And chest deformities. Yes. So now next is going to be distress. How do you know if your patient is in distress or not? What are we looking for? Vital signs. Yeah. Keep going. Anything else? So I would know, can speak in complete sentence, correct. Anything else? Excessive use of respiratory muscles, correct. Sweaty, yes. Cyanosis. Respiratory distress. So you want to know if there is any breathing through purse, mouth or lips. Are they leaning forward? Can you see the respiratory muscles, intercostal muscles being used? So say all of them. I am looking for signs of distress, and these are the things I'm looking for. Why are we looking for lines and devices? What is more important for a cardiovascular system examination? Why do we need lines? Why are we looking for devices? Pacemaker, you're right. You want to look for pacemaker. And bedside, you want to look for medication. Is there a GTN spray? Is there a warfarin booklet? Are we giving oxygen? Is there a glucose meter for monitoring? Is there a fluid balance chart? Is there a mobility aid? Is there a frame or a walking stick? Whatever the patient is using, acknowledge it. It's really important. So tell me, what is this? Who can tell me what this picture shows? Muffins. But you know what actually that is? The anatomical term? No, that's clubbing. This one? Arachnodactyly. Yes. And this one is clubbing. And what about this?
Splinter hemorrhage.
Okay. And this one?
Janeway lesion.
And this one?
Osler nodes.
Okay. So which one is painful? Janeway or Osler?
Osler.
Good. You done well. Okay. So the arms and the neck. So we always start with temperature. And we need to know the capillary refill time. Why are we very particular about capillary refill time in a cardiovascular system examination? Why do we always say that we want to shock?
Perfusion.
Yeah. So you want to know if your patient is in shock. So capillary refill time in a cardiovascular system is mandatory. So onto the nail, what else can you see? So there are 3 C's in the nail that we normally look for. So we look for clubbing, capillary refill time, and what is the other C? Yep, clubbing, capillary refill time. There should be one more C. Do you know what that is?
Cyanosis.
Correct. Peripheral cyanosis. So specify, is it going to be central cyanosis or peripheral cyanosis? So in the fingernails, we're going to do clubbing, capillary refill time, and cyanosis. Then we turn the hand around to see if there is any Janeway lesion, Osler's nodule. We also want to look for any palmar crease pallor. Why am I looking for palmar crease pallor? Again, it's important in cardiovascular system examination.
Anemia.
Correct. So we're looking for signs of anemia, because if there is a murmur, I want to know, is it because of an anemia? So I always need to look for palmar crease pallor. Now we check the radial pulse. So when you check the radial pulse, you're checking for the rate, rhythm, character, and volume. We need to check the radial delay. Why are we looking for radial delay? Coarctation of aorta, where? It's important where it is. Before the subclavian, right?
Yeah.
So, and what we are looking for collapsing pulse. Why are we looking for collapsing pulse? Aortic regurgitation. Okay. So when you check for the collapsing pulse, there is something you must do before you check for collapsing pulse. Do you know what that is?
Ask him for the shoulder pain.
Yes, because you cannot harm your patient. Do no harm. So ask the patient, do you have shoulder pain? Once you confirm they don't have pain, then you say that I'm going to lift your hand and checking for the collapsing pulse. All right. So in normal cardiovascular system examination, we don't have to do the blood pressure. They have blood pressure separately. And if you have a patient with heart failure and they give you a blood pressure, what must you ask? So they've had recently a case where they have a heart failure case and they've asked you to do the examination, or the patient was going to be discharged or something like that. And then they gave you a blood pressure reading. What should you ask? You should ask, was it sitting, standing, or lying down? Because for a heart failure patient, when we discharge, we need to rule out orthostatic hypertension. So if they've given you a reading, you really need to know what was the patient doing at the time of reading. And then you need to measure the other one. So if they were sitting, you need to make them get up and do it. So lying down, sitting, whatever. So you must also auscultate the carotid, then only you palpate it. Why? Do you know why we have to auscultate the carotid before we palpate it?
Carotid blue.
So we always auscultate first, okay? And you use the bell or the diaphragm or the stem.
Bell.
Why? Medicine makes sense if you think about it. Why? Why do we use the bell? Low pitched. Yeah, low frequency. Correct. I'm enjoying teaching you guys. You're responsive. All right, now we check for the JVP. So obviously, if there is JVP raised, how do you measure the JVP?
From the sternal angle. Asking the patient to look to the left side.
So we need two rulers. So they will have to give you two rulers. So you ask the patient to turn the head to the left from the highest point where you can see the JVP. From there, you stick a ruler out. Another one will be from your sternal angle where they meet. That is the height of the JVP. So what is a normal JVP? When do you call it normal?
Less than 4 centimeter.
So up to 4 centimeter is fine. Anything more than 4 will be abnormal. So the next thing you got to do is hepatojugular reflex. Why are we doing the hepatojugular reflex? There must be a reason we're doing it, right? Anyone? So normally, if you press on the liver, so what will happen to the blood in the liver? It's getting pushed out.
Increase venous return.
Keep going. Let me hear. So why are we doing hepatojugular reflex? So when I'm pressing on the liver, what will happen? Right-sided heart failure. But why? How do I know from hepatojugular reflex that there is a right-sided heart failure? Portal hypertension, yeah. Then? So you're pushing the blood through the IVC, right? So if there is a lot of blood on the right side, then the JVP is going to be sustained. It will not come down. So in a normal patient, the heart is functioning. Yeah, sustained enlargement of the IVC. That's why. So that's why we do the hepatojugular reflex. So when we do the hepatojugular reflex, you need to ask the patient again, do you have any tummy pain before I do this? And tell the patient, I'm going to press on this, and I'm going to see if there is a sustained JVP. Clear so far? Any questions so far? No. Okay, good. All right, so what am I seeing here?
Pallor, conjunctival pallor.
And this one?
Arcus senilis.
This one?
Is it a genitalism?
This one?
Taylor fissuring.
This is Roth spot.
KF's, the Kaiser Fleischer ring. And this one is?
Angular stomatitis.
Angular stomatitis. So all of these things you need to remember. So this is easy. I usually tell my students that this is the itis. So you're looking for angular stomatitis, glossitis, gingivitis, and angular stomatitis. And inside the mouth, you still need to look for dental hygiene. Why am I looking for dental hygiene?
Infected endocarditis, dental abscess.
Good. So chest inspection, you really need to, so by now, you know, I can't draw to save my life, right? So I had to copy this from my university resources. So A is going to be the midline sternotomy. B is going to be your anterior thoracotomy. C is going to be your posterior lateral at the back. D is going to be your clamshell. And E is going to be your subclavicular. This is really important in cardiovascular system examination because this is where the pacemaker scar is always seen. So we are looking for anterior chest wall would be that pectus excavatum, pectus carinatum. If you actually look for kyphosis and scoliosis anteriorly, I, as an examiner, will fail. Because you can't see kyphosis and scoliosis anteriorly, you'll have to look laterally and posteriorly. So pectus excavatum and pectus carinatum need to be looked at. Visible pulsation need to be looked at. So by now, you should know where your mitral area is, aortic area, pulmonary area, tricuspid. So looking at the sternal angle on the left and the right, so you have aortic, pulmonary, tricuspid on the fourth, and the mitral on the fifth intercostal space, mid-clavicular line. And this should be in your head. So this is not difficult at all. So if the apex plate is pushed further away from the fifth intercostal space, mid-clavicular line, what would you say to the examiner?
Displaced apex plate.
So if it is pushed, it'll be hypertrophy where?
Left ventricle.
Okay. And if you find a parasternal heave?
It will be in the right heart failure.
It will be the right ventricle, right? Usually? Yeah. Right ventricular hypertrophy. Okay, so these are the things you can tell the examiner once you remember. So if the apex plate is pushed further away, it's going to be LVH. Parasternal heave is going to be the right ventricular hypertrophy. So palpate the apex plate, then we know where it is. And heaves is going to be what this is. So a thrill is a palpable murmur. So you put your hand on all of the valvular region and then say that I am listening for the palpable thrill, or I'm feeling for palpable murmur. So you want to auscultate. We start with the bell at the mitral area, then we change to diaphragm, and then we can do the cardiac dynamic maneuver. You need to know how the dynamic maneuver is done, because there is a case where they can ask you to the cardiac murmur examination. So you need to know where the radiation of the murmur is and how to do this. Okay, so aortic stenosis, we are going to auscultate over the carotid artery because it's going up, so you can hear it. Aortic regurg, we are going to auscultate over, again, aortic area with the diaphragm. You sit the patient forward, listen during the expiration. So the right side murmur is inspiration, while right side murmur is inspiration, left side is going to be expiration. Then mitral regurgitation, you auscultate over the mitral area with the diaphragm, roll the patient to the left side, listen during the expiration. Mitral stenosis, auscultate mitral area using the bell, roll the patient to the left-hand side, listen during expiration. So these things you need to know very clearly. Have you guys watched this guy? He's my hero.
Yes, sir. After writing T-Pen, and here's the trick. For syndrome members, these two S's limited get horizontal sound. Tricuspid regurgitation, pulmonic stenosis, aortic stenosis, and mitral regurgitation. After typing, the exact opposite. And on the side, get RSNA. You got it. Tricuspid stenosis, pulmonic regurgitation, aortic regurgitation, and mitral stenosis.
Cool, eh? I have probably watched every single one of his videos. Okay, so aortic stenosis is ejection systolic murmur, slow rising pulse. Aortic regurgitation and diastolic collapsing pulse, Quincke's. What is Quincke's? What is Quincke's sign? No? The nail bed, pulsating nail bed. Dumasset?
Head nodding.
Corrigan's? Water hammer. I already explained what water hammer is, right? So the collapsing pulse Corrigan is the same. Mitral stenosis is mid-diastolic murmur. Mitral regurgitation is pansystolic murmur. So this is where all of it, you can find this chart in the internet. This is my uni resource, but you will find the same thing in the internet. It's really important that you go through this. So to complete the exam, you need to inspect the posterior chest wall, you percuss and auscultate the lung fields, you assess for sacral edema, you assess for pitching edema. You need to thank the patient, you need to dispose of the PPE if what you're using. Summarize your find. You may not have some time to summarize, and that's fine if you don't have time to summarize. Okay, but it is really important. So you need to remember that when you leave the room, your examiner has to put the room exactly how it was when you entered. So it is important to put everything back so that the room is back to what it was before. Because the examiner only has 2 minutes. While you're reading the station outside, the examiner is finishing off the marking and then getting the room ready for the next doctor that is coming in. So please make sure whatever you used, put them away or throw them away if it needs to be thrown. And you must thank the patient because they're doing a fabulous job being your patient that moment. Please thank the patient. So signs of heart failure, infective endocarditis, prosthetic valve coarctation of aorta, and aortic stenosis. So heart failure, you're looking for tachypnea and tachycardia. Is there any cool peripheries, raised JVP, displaced apex? You can often get a third heart sound, bibasilar Krebs, and peripheral edema. Infective endocarditis, you're looking for fever, heart murmur, oscillar nodes, Janeway's tachycardia, and splendour hemorrhage. A prosthetic valve, midline scar would be there, multiple bruises on the arm, click sound on auscultation. Or coarctation of aorta, radiofemoral delay, weak radial pulse, hypertension, thoracotomy scar, signs of heart failure, not always. A splendour hemorrhage, you can still get an coarctation of aorta. Aortic stenosis, remember SAD, syncope, angina, and dyspnea. Ejection systolic murmur over the aortic valve, slow rising carotid pulse. So the SAD is what I remember aortic stenosis always. So syncope, angina, and dyspnea. So this is your quick OSCE revision CVS. So if you have a 54-year-old man present with severe central crushing chest pain, which radiates to jaw and arm, he has a past medical history of type 2 DM and high cholesterol. He also is a heavy smoker and rarely exercises. Diagnosis? No? Triple A? Think. MI? Yes. Acute coronary syndrome. I would go for ACS. All right. A young woman present with pleuritic left side chest pain, not able to take a full breath, currently on OCP, recently came back from traveling. Diagnosis? Good. 23-year-old, thin male, presented with sudden onset right side chest pain, shortness of breath, very sharp pain, worst on movement, sudden during a hockey match with no history of trauma.
Pneumothorax.
Spontaneous.
Spontaneous. You need to use the word spontaneous. Okay, good job. Yeah, 55, presenting with sudden onset of tearing chest pain radiating to the back and scapula. Significant history of hypertension.
Aortic
Now
dissection.
see that difference between this and this. Okay. 65, female, chest pain improves when sitting up. Pain is sharp, doesn't last long. Recently had an upper respiratory tract infection, has a fever. There are ECG changes present.
Pericarditis.
60, female, chest pain while walking upstairs. Pain resolves once taking her GTN spray and rest.
Stable angina.
Good job. Okay, so we go back to the score sheet. This is how you do the cardiovascular system examination. So wash your hands, introduce yourself, you identify the patient. You really need to ask the patient. I know a lot of tutors say that you don't need to know the patient's name because they've already said that, but clinical error is one of the biggest threats to patient safety in Australia and globally. You really need to know your patient's name and their age and confirm that you have the right patient. Not only for the AIMS exam, for the rest of your life. Ask for permission, check for pain, position the patient, and exposure. So end of the bed, you're looking for signs of patient's distress. Are they speaking difficulty? Is there any posture problem? The posture of the patient, any diaphoresis? Lines of devices, so oxygen, any IV given, any IDC, cardiac monitoring done. Surrounding environment, you're looking for medications, puffers, sputum mug, mobility devices, hearing aids. Body habitus, obese, normal weight, underweight, cachexic, state of nutrition, syndromic features of the face and the hand, downs, Marfan's. Posture, are they having a thoracic kyphosis, thoracic scoliosis? Examination of the peripheries. You start with the hand, finger clubbing, maybe present in infective endocarditis, cyanotic congenital heart disease, chronic respiratory conditions. Is there peripheral cyanosis? Capillary refill time, normally under 2 sec. Shape of the fingers, long and slender, is muffins, and spade-shaped fingers is acromegaly. Nails is going to be splinter hemorrhages in the nails, maybe caused by trauma or a sign of infective endocarditis. Palms and the palms of fingers, you're looking for osseous nodule. Osseous is ouch, and it's painful. That's how I remember. The inhalation is not painful. Pallor of the palmar crease, you need to look for anemia. Tendon xanthoma is important. Why? I usually ask my patients to play an imaginary piano. Why am I looking for tendon xanthoma?
Hypercholesterolemia.
Good. So we also need to, in cardiovascular system examination, you need to look for rheumatoid nodules. So wrist, radial pulse, rate, rhythm, character, and volume. Check for radial delay. And then we want to know, you don't have to do radiofemoral delay, but tell the examiner that if there is a need, I would do the radiofemoral delay. You will check for collapsing pulse after checking if they have any shoulder pain. Pulse is altering, so alternating strong and big pulse, and usually is a sign of LVH. Blood pressure, don't do this, just acknowledge that you have to do it. Onto the face, you want the eyes, you want sclera, check for jaundice, conjunctiva pallor, signs of anemia. Xanthelasma, so yellow or gray plaques around the eyes may be normal or indicative of a familial hyperlipidemia type 2 or type 3. Arcus senilis, the gray ring around the eyes, this is normal in elderly, but suggestive of cardiovascular risk in a younger person. I'm scared. I always check in the mirror to see if I have arcus senilis. Cheeks, mitral phases, rosy cheeks. Why do we get the rosy cheeks? Does anyone know? In mitral stenosis? No? If you figure it out why you get malar rash, but what malar rash is, the rash would not be, so the faces is that pink cheese. Malar rash would be for scleroderma, right? SLE, sorry, not SLE. So malar flush is what we're looking for. But why are we getting the malar flush in mitral stenosis? Once you find the answer, you can message me, okay? I'm not going to tell you everything. But it's a curiosity that makes you a better doctor. So mouth, you're looking for high arch palate, for muffins, one of you said earlier, enlarged tongue for acromegaly, dental hygiene, because that's often in a endocarditis, and bluish discoloration of the tongue or the lips for central cyanosis. The neck, you know how to do that. Ask the patient to turn to the side, you measure the JVP, see if you can see the jugular venous pulse. How do you know you're not, how do you know it is JVP and not something else, not an artery?
Not pulsatile.
Okay, and? You can obliterate, you can press it and you can obliterate it. There's an artery, you cannot obliterate it. Okay, as this for the height and the character, and then we need to distinguish, yeah, that's right. You need to distinguish from the carotid pulsation. So it's usually a double flicker, not palpable, moves on respiration, obliterated by live pressure. I'm surprised I've written that. Okay, at the base of the neck and fills from the above. You need to measure the JVP using the 2-ruler method. So vertical height of the column of the blood above the sternal angle. If it is greater than 3, consider it raised. I thought it was 4, but 3. Okay. Character, they won't usually ask, so you can ignore that. Carotid pulse, never palpate both together, always auscultate, and then you do the palpation. Scars, you have to look any surgery. I usually also ask the patient to lift their hand to see if there is any thoracotomy scar. And then we need devices. And then so inspection is any visible apex speed. Palpation, feel for the apex speed, fifth intercostal space. If it is pushed, acknowledge that, explain why it is. And then if it is pressure loaded or volume loaded, no, they won't ask that. You don't need. Heaves and impulse. So you place your hand on the left sternal border. And if there's a heave, that is because of left ventricular hypertrophy. Trill is a palpable murmur. So you palpate all of the valvular region to see if you can feel any murmur. Auscultate. So you have to say that I'm listening for S1 and S2 or any added heart sound. And if there is a murmur, you're going to do the dynamic maneuver. I already explained to you how to look for the heart sounds. And then we know all of the dynamic maneuver. So at the back, you're going to percuss the base of the lungs. You're also going to auscultate, and then you want to palpate. So when you palpate the sacral edema, you need to tell the patient that I'm going to pull your underpants a little lower just to see if there's a sacral edema, because you won't be able to get to the sacrum if in a normal patient that's sitting down with their underpants on. And then you want to position for the abdomen, tell the examiner that I will still need to, in order to complete the examination, I still need to do the abdominal examination. What are we looking for if you have to do the abdominal examination? So we need to look for any ascites or any organomegaly, any visible pulsations. So is it a caput medusae or an IVC obstruction or an SVC obstruction? How do you know if it's an IVC or an SVC obstruction? If you see an engorged vein? There's a way you can figure it out. Does anyone know? Using the 2 fingers? No? Have you done it? Have you seen patients with engorged vein and you can do 2 fingers to figure out whether it's an IVC or an SVC obstruction?
Uh,
No?
yes.
All right. Tell me how.
So we have to put the two fingers, and if one finger lift it up, if that feeling, imagine in the up, it should be likewise SVC. Otherwise, if not feeling the inferior vena cava, might be vice versa.
Okay, you got it. Yep, filling of vein from below upwards is IVC obstruction. Good job. Okay, so we did that. Liver for hepatic enlargement, tender liver is for heart failure, pulsatile liver is tricuspid breakup. Lower limb, you're looking for, still look for tendon xanthoma, any peripheral cyanosis, capillary refill of the toes, signs of peripheral vascular disease, temperature for the cold peripheries, peripheral edema, calf tenderness for DVT, and feel the pulses bilaterally. You may not have time to do all of this, and that is fine. If you can just check for edema of the limb and also any hair distribution or temperature, you still will pass. So after the examination, please put everything back in the original place, wash your hands, and thank the patient and the examiner, and then leave the room. So for the AMC exam, you don't really have to sanitize your hand as you leave the room, because when you enter the next station, you still have to sanitize. So when you come out of the room, they ask you to take left, and then you go to the next room. So there will obviously, you'll have to sanitize your hands. So you only need to do it one time when you enter the room. You don't have to do it when you leave. Any questions so far? Is there anybody who wants to try doing a cardiovascular system examination? I can put the timer on. Who is brave? Simple, right? No one brave? Come on, guys, you can make a mistake. That is how you learn. How many of you today? There's 24 of you. There should be one of you who is brave enough to take this. No? That's okay if you're not. All right, so this is how you practice, and this is what you need to do for cardiovascular system examination. So I have, these are the social media where I have my social media account, whatever that is. Someone is coming very late, so at the end, sorry. And I have something that I would, just give me a second. I stop share for a second. I need to open to see where it is. Okay, so I have something. This is what I used for my exam. So I use a Kanban board. I don't know if you've heard of this, and most of my medical students use the same thing. So all of the topics that you need to know for your AMC exam is categorized and it is sorted. So mental health will come like this. So what I do is that if I've studied, I move them to each area. So they move. So they all can move to different sides. So all of the topics are categorized. And once I've finished, I go move them because I don't know about you guys, I'm a visual learner. So I need to see everything to understand what I'm doing. So this is a Kanban board. And so like for pediatrics, all the topics are categorized. So once you've done it, if you haven't started or if you are in progress, you move here. If you have done it, you move to the other end. So you can see what your progression is. So this is geriatrics, and then obstetrics and gynecology, cardiovascular system, respiratory, gastro, renal. There's a lot to go through. Musculoskeletal, acute and emergency, neuroscience, endocrine and metabolism, infection, cancer. These are all of the questions that AMC asked in the last 5 years under category. So they've asked basal cell, they've asked bladder cancer twice, breast cancer, cervical cancer, colorectal cancer, endometrial, gastric, leukemia. So these are all the cancers AMC has asked. And these are dermatology and your hematology cases, your nose and throat. So everything is categorized. And if you would like to get this this is my work. I have spent a lot of time doing this, but only on one condition, that you follow me on all of the social media. And then if you can send, if you're followed and take a screenshot and send it to my admin in the Telegram, BSK, he will send you the chart if this is useful for you. All of the material will be given. All right, so that completes our AMC cardiovascular system. And what else? Is there anything else you want to ask?
Doctor, excuse me, I know that you are going to give a physical examination in Brisbane, face-to-face classes.
Sorry, can you repeat that again? I couldn't hear you.
I would like to know when are you going to have the face-to-face physical examination in Brisbane?
Okay, so I run face-to-face examination over 3 days in Brisbane, and it usually gets fully booked in advance because I'm the only one who is offering PE in Brisbane.
Perfect. And how can we get access to the course or to the class?
So physical examination is separate. So if you are doing the one-to-one course, so I have 30 hours course or 60 hours course that is one-to-one. And if you're doing the 30-hour course, the physical examination is usually taught free. And I have doctors who fly in from Sydney and Melbourne to come and attend the physical examination. They usually stay in Brisbane and we go through usually it'll take 2 days and sometimes 3 days. And then they learn PE. That is free for those who take the 30 hours and 60 hours class. So the 30 hours also get mock exams and physical as free. Both 30 and 60 get mock exams and physical examination free. But otherwise, you will have to pay for, if you're only taking the physical examination, you will have to pay for it.
Okay. And because I was trying to book in the page, but I think I have to send an email first in order to get access to the course.
Yes, you do.
Okay. Thank you.
You're welcome. Any other questions? Was this session useful to you guys? Did you learn anything? Yeah? I'm glad. I think if we all work together, yes, my course is expensive, but that doesn't mean that I cannot help you guys. I can still do these sessions once in a while. Next week, next Wednesday. I'll do this every Wednesday. So next Wednesday, Kristlyn is doing sexual history. So she is a trained counselor. She's brilliant. So she will run the session next Wednesday. And the tickets will be given on Eventbrite and still free. So you need to book. And we can only do 50 because I don't want to deal with more than 50. So book the ticket and you can do this. And next week's session will be at 6:30 rather than 7:30 because she is in New Zealand, so I need her to sleep. She can't stay awake that long. So 6:30 next week and 6:30 Brisbane time. So I will see you. If there's no other question, I will see you guys next Wednesday. No, doctor, I live in Brisbane. My life revolves around Brisbane. So no plans for, you can fly to Brisbane. I have a lot of doctors coming to Brisbane. So they buy the ticket when it is $90 from Sydney and they come and stay. You can message me. So so you have my number. It is, if you're in Australia, I can give you my number, 04-5262-3696. Or you look at my website, all the details are there. Message me, doctor. You guys are fabulous. Thank you for participating. It's very difficult to teach when you don't have participation. All right. Enjoy the rest of your evening and good luck with your AMC exam. And as I say all the time, if I can pass the AMC exam, anyone can. I'm not the brightest spark. You guys are fabulous doctors. Believe in yourself. Take this seriously. Make sure you practice. You will pass the exam. All right. Goodbye. Bye, doctors.